Hello, I'm Christie Ballantyne. I'm delighted to present a very quick update going through the 2022 ACC expert consensus on the role of non-statin therapies. Expert gratitude as one of the co-authors of this guidelines. These are my financial disclosures. So what's new? There's a consideration of some of the newer, more recently approved FDA-approved agents since 2018 at the time that we had our guidelines come out. There's a new LDL cholesterol threshold in patients with ASCVD and very high risk. The value statement for PCSK9 monoclonal antibodies has been taken out. Earlier initiation of combination therapy, when we use ezetimibe in high-risk primary prevention in PCSK9 monoclonal antibodies, and just some guidance on non-statin therapies in patients who have statin-associated side effects. So, as you know, we've got a number of non-statin therapies. The PCSK9 monoclonals, highly effective, reducing LDL cholesterol about 60%. Ezetimibe, used in combination with statins, highly effective as monotherapy, 18%, but with statins you're getting 50, 60%, and 70% even with high efficacy statins. Bile acid binding resins also can be used in addition to statins. We don't have outcomes data with those as compared to the other two on top. Bempedoic acid, and I'll show you some new data that came out at the ACC on bempedoic acid for statin-intolerant patients, and inclisiran and siRNA, and evinacumab as a monoclonal antibody infusion, but it's only indicated for homozygous FH and gives about a 49% reduction in LDL cholesterol, even in the patients with no LDL receptor, so really quite fascinating. So a lot has happened with non-statin therapy, and we focus on statins because we have a huge amount of trial evidence. But our first set of guidelines in 2013 that mentioned really just talking about statins alone, there weren't any data. Now, since then, we've had a lot of studies coming out, Improvement, Fourier, Aspire, Reveal, Odyssey outcomes, 122,000 patients, plus more recently the CLEAR outcomes. So we really have a lot of data that there's additional benefit adding non-statin therapies to lower LDL cholesterol. So this is one of the reasons why this pathway talks about when you have the very high-risk patient, that in fact the threshold, instead of being 70 for considering adding something else, it's 55. And that's mostly from the data from the Fourier Odyssey outcomes trials, where it showed that getting LDLs down to around 30 were the optimal zone for very high-risk patients. Improvement was 54. Now, when the last set of guidelines came out, since then the price of PCSK9 monoclonal antibodies has been changed fairly drastically, so there's no longer a value statement in this pathway. Combination therapy, when should that be initiated? Well, I think it makes more sense, and we see the data in terms of efficacy to start earlier. One of our big problems in regards to treating patients is in the field of lipids is we fire and forget. You put them on a statin, and that's the end of it. No, don't check the lipids, and don't get the patients to the optimal level of LDL cholesterol. So that's been changed here. You can go with combination therapy right off the bat if it's a very high-risk patient. There's no reason not to go with statin and ezetimibe. If you think you need to get a very major reduction, you could always reduce it later on. What about calcium scoring? Where does that fit in? It's become a widely used test because it's a very powerful prognostic indicator of future events. So a couple of roles. One of them, when you're seeing that patient and you're sitting on the fence, what do I need to do here? If they have a 0, well, it gives you some room to work on lifestyle and other factors. You know, it's a little bit of a very low event rate for the next 3 to 5 years. Now, if they have calcium, how much calcium, and also what is their basically age, sex percentile. So if they're low calcium and less than 70th percentile, you might use a moderate dose because they have some plaque, not a lot. However, if it's over 100 and greater than 70th percentile, you're probably thinking about a high-intensity statin. And if it's really high, in this case, we chose a cut point of over 1,000, but in a younger person, you might consider something lower than that. Then even more aggressive therapies to try to get LDLs far down in consideration of not only ezetimibe, but also PCSK9 inhibitor. What do we do about the challenging patients with possible statin-associated side effects who are unable to tolerate a high efficacy statin at an appropriate dose that will give them that 50% reduction? Well, we've talked about some of the data, but let's talk about a new study that came out after this pathway, presented at the ACC meeting this year, the Clear Outcomes Trial. This enrolled individuals who had statin intolerance defined as couldn't take 2 or more statins or had 1 statin, unwilling to attempt a second statin, or advised by physician, do not attempt a second statin. Placebo-controlled bempedoic acid, 180 milligrams, versus placebo, endpoint-driven, up to 1620 primary 4-component MACE, a 10 key secondary 3-component MACE, greater than 24 minutes of follows. Now, it was interesting. This trial was about half women. And that's important because women are more likely to have symptoms of statin intolerance. So it's important in terms of following the LDL cholesterol and the response to therapy. You could go into this study, about a quarter of the people were on some statin usage, just below the recommended starting dose, lots of diabetes. And notice it was a mixture of secondary prevention, 70%, and 30% high-risk primary prevention. Well, what were the results? LDL cholesterol went down, as you'd expect with bempedoic acid. It's a little over 20%, but the placebo group, notice, had a lot of drop in therapy. So it also started going down over time with it. CRP was also reduced. And what were the outcomes? Well, the primary outcome, there was a hazard ratio of 0.87, so at 13%. For the hard outcome of the 3-component MACE, it's a 15%, both of these highly significant in regards to event reductions. So we kind of very quickly went through talking about where do the new agents fit in. We talked about a lower LDL-C threshold of 55 in your very high-risk patients. Earlier use of combination therapy, using ezetimibe in high-risk primary prevention. PCSK monoclonals, if you've got a very high calcium score, could also be considered because they have extensive subclinical atherosclerosis. And also there was some guidance on non-statin therapies in a recent outcome study showing the benefit in a non-statin therapy for people who are statin intolerant. Now we have this information, but what's happening in practice is usually not very much. High-intensity statin usage has increased over time. Very little combination therapy, but it's still 60% in the Gould registry. I was part of that registry of the steering committee. Sweden, it was great, very great in Sweden for high-intensity statin post-ACS, but almost no combination therapy. Now in the Gould registry, in terms of hypertension, the same healthcare practitioners, 70% on combination therapy versus, as you can see here, about 8 or 9% for lipids. So why are patients not optimally treated? Well, the guidelines do keep changing and they're getting lower. The high-risk patients have lots of comorbidities, they're on multiple therapies. There's pushback sometimes on using a high dose of a highly effective statin. I think there's not enough combination therapy usage, and also there's the whole issue of adherence and also cost of medications, something where some of these non-statin therapies such as inclisiran may make an impact on adherence. Well, there's a lot going on in the area of PCSK9s. We've got the monoclonals, we've got inclisiran, and most recently at the ACC meeting I presented the data on an oral molecule. This is a macrocyclic peptide. Very fascinating story because I was told you couldn't make an oral molecule in terms of making an inhibitor, but very potent with a biotech approach towards identifying and creating this molecule. And then what was done in a study, we showed in a phase 2 study, a dose range study, that at the 2 higher dosages of 18 and 30 milligrams, about a 60% reduction in LDL. So in addition to this, there's a lot going on in the field. Lipoprotein A, another important risk factor, genetic. We've got 2 outcomes trials. One is fully enrolled with pelacarsen, another one, olpasiran, is still enrolling. They're highly effective in regards to lowering the levels of lipoprotein A, and there's more in the pipeline, other agents. In regards to high triglycerides, we've got ApoC3 inhibitors, ASOs, siRNAs, ANGPTL3 inhibitors, and FGF21 analog. There's a lot happening in the areas here. If you have, I got to put a plug in, if you have patients who have very high levels of lipoprotein A and clinical CVD, we've enrolling right now for our siRNA outcomes trial, gives a 90% reduction. High triglycerides. We've got some very exciting studies using an antisense oligonucleotide. This is the information for contacting it, or you can email me or ccdp@bcm.edu. Thank you very much.